Good morning. Welcome to our CU session every Saturday. So today we will be having Dr. Joseph, who will be doing a critical appraisal or using a checklist called Inspect SR, something which is new that we have not done before. We have looked at assessing risk of bias and how to address bias, but this is something different. So we thought we'll venture into this as well, and I'll hand over to Dr. Joseph for the further discussion, and we'll open for questions at the end of the session. Thank you.
Thank you, sir. In today's session, we'll be seeing about the Inspect SR checklist and how to apply the same on a randomized controlled trial on metformin and COVID-19. So what is exactly Inspect SR checklist and why do we have to use it? So many times we come across many trials which are never retracted, and by the time they're retracted, it's almost about 4 to 5 years before a study is retracted. And if at all some systematic reviews are being conducted using those studies, they might have already included those studies in the systematic review before the retraction status is officially put up. So this Inspect SR checklist can help us assess the trustworthiness of a trial. And uh, before we could include the study in a systematic review, it will help us to assess the trustworthiness of the trial. And many problematic studies can have a sound methodology, but still it can contain false or fabricated or erroneous data, which can be detected by using the Inspect SR checklist. The Inspect SR checklist is a 4-domain checklist and has 21 checks under it, and it helps to assess the trustworthiness of RCTs. And the concerns about trustworthiness does not always amount to misconduct, and it does not essentially mean that the study has conducted fraud. It can just be an error which was not noticed while the study was being done. So usually before we include a study in systematic review, it is normal for us to use standard risk of bias tools like ROB or GRADE tool, which will assess the authenticity of, which will not assess the authenticity of data, but will just help to assess the things like randomization and all, or whether they are accurate or not. But here, this tool will help us to assess the authenticity of the study before we can do a systematic review. So a study can be problematic because of research misconduct, which can include plagiarism, falsification, or fabrication of data, which will not be ideally detected using the risk of bias tools. And these studies, if they are not adequately assessed for trustworthiness, they can also change the outcomes of a systematic review, and it can lead to harmful treatment recommendations, which are misleading or even can be harmful. So the structure of the Inspect SR tool, it has 4 domains. The first domain involves assessment of post-publication notices. Domain 2 is to assess the study's conduct, governance, and transparency. Domain 3 assesses the study's text and figures. Domain 4 involves assessment of the results of the study. There are 3 checks under Domain 1, 5 checks under conduct, governance, and transparency. There are 2 checks under text and figures, and 11 checks under Domain 4, which is the results of the study. Under each domain, we'll be rating it as either no concerns, some concerns, or serious concerns. And overall, after doing assessment across 4 domains, we'll give an overall study judgment again as no concerns, some concerns, or serious concerns. So this is again the image showing the similar 4 domains of the checklist and give an overall assessment for each of these domains and giving an overall study judgment based on all these 4 domains. So before we go into the critical appraisal using the Inspect SR checklist, I would like to put forward a clinical scenario. Here you come across a 52-year-old male who has presented with mild COVID-19. He has obesity and does not have any other risk factors for severe COVID-19. And your colleague in the hospital suggests to start metformin for this patient based on many observational studies that he came across. So before you could start metformin, the doctor here decides to do a systematic review about metformin and COVID-19 to understand the study's evidence. During COVID, we had multiple studies coming up at that point of time saying like hydroxychloroquine is beneficial, azithromycin is beneficial. But subsequently, we came to know that many of these results were inconclusive and there was no effect on COVID-19. So whether this study is whether the metformin is beneficial in COVID-19, this doctor decides to do a systematic review, and she came across one trial called the Together trial in about metformin in COVID-19, and she's little doubtful whether she should include this study in her systematic review or not. So how do we decide whether to include this randomized control trial within a systematic review? So before we could do that, we'll be applying the Inspect SR tool to assess the trustworthiness of this Together trial, and we'll decide whether to include it in the systematic review or not. So the article chosen for appraisal is the Together randomized platform clinical trial, which assessed the role of treatment with metformin on risk of emergency care and hospitalization among patients with COVID 19. So the Picot statement of the study, the population included were adults more than 18 years who were symptomatic with COVID-19 for less than 7 days with at least one risk factor for severe COVID-19 or aged more than 50 years without any risk factors. The intervention given was metformin at the dose of 750 milligrams twice daily for 10 days. The control arm received a similarly labeled placebo. The design of the study was an adaptive platform randomized control trial which used a Bayesian framework for reporting. And the study was done in Brazil. The total number of samples included in the study were 418. The primary outcome of the study that it looked at was subsequent hospitalization to a tertiary care center or retention in the emergency setting for more than 6 hours. And the time duration for follow-up was 28 days for each of the patient. So this was an adaptive platform trial wherein multiple different treatment arms were there, and it was dynamic and adaptive so that if any drug was not shown to have any benefit, it was removed. And if newer studies came up showing benefits of certain drugs, these drugs were added on to the ongoing randomized control trial. So coming to the first domain, which involves inspection of the study's post-publication notices. The first question under the study was to find out whether the study has an associated retraction, for which we have given serious concerns, because when we looked up at the journal on Lancet, we noticed that the study was retracted. The reason that was given was that there was a problem with the number of population that was considered under risk, and the number of primary outcome events was also given as inappropriate and incorrect. So if we are looking at a randomized controlled trial, whether the study was retracted or not, how all can we look at whether it was retracted or not? We can look at the directly, we can go to the journal per se and see whether there's any retraction notice or not. Another way to look for retractions is to go to the website called as retractiondatabase.org. So I'll show you just how to use the retractiondatabase.org tool. So if you go to retractiondatabase.org, here we have an option to search for any article to assess the retraction status. We can search by either author or the title of the study or the article type or the journal, or if we have the DOI per se, we can enter the DOI per se and search for the same. So here I'll try to enter the primary author of the study. And when we click search, the website does a search to find out if there are articles written by this author and if they were retracted or not. So when we enter this article, this author's name, here we come across that this study was retracted. The same study that we are appraising, which is the effect of metformin on risk of emergency care and hospitalization among patients with COVID-19. The website also lists the reasons for retraction, which includes errors in data, investigation by third party, and because of unreliable results. Here we are seeing the other authors included in the study. And using this website, we can look at any article to assess for its retraction status. So if an article is retracted, it's given as serious concerns here. And for any article that we're critically appraising, if there are if an article has been retracted, it gives an overall judgment of serious concerns for the entire study per se. And if at all a study is retracted, it is the study should be marked as such on the journal website, and there should be a separate published retraction notice with a unique digital object identifier in the research journal website. So again, I'd like to emphasize that this methods of checking for retraction, one involves checking the online version of the latest version of the publication on the journal's website, or we can search for the use the retraction database to check and enter the details of the study to check for the retraction status. So if at all we are planning for a systematic review, it would be ideal to do the same just before finishing the systematic review to identify any latest retractions of the study. So second question is, was there any associated expressions of concern or post-publication notice given for the study? For this, again, we have given a yes, because in 2024, the Lancet has also published an expression of concern prior to official retraction of the study. What are the other ways through which we can check for post-publication notices? One is to look for the journal's website. The second, again, we can check the retraction watch database to check for post-publication notice as well. And we can also look for citation search in Web of Science or Scopus. And there is also another plugin called as the PubPeer plugin, which we can use to find out if there are any expressions of concern for any of the study that we would like to consider. So this is the expression of concern that was published in January 2024 in the Lancet study because they detected errors in the total population that was considered for analysis in the study. So this is one example of using the Papier tool. We have the Papier tool which can be downloaded and added as a plugin to any of our browsers. And any article that we browse or look up for this Papier plugin, if it's installed, it will show us some comments if there are any significant comments about the study which has been put up for each of these articles. Just by clicking on this green colored link, we'll be going across to the comments that has been put up for each of the study that is under question. So, for example, I did a search about using hydroxychloroquine and azithromycin as a treatment for COVID-19, and the Papier login showed two comments about this article. One was that the article describes one 37-year-old woman included in the study in the local newspaper, but when the person who had put up this comment had searched in the study's a database, there was no 37-year-old woman available in the data set. So this person has pointed out that there is an error in the study. And there are also some problems with regards to the informed consent, wherein one participant of the study had said that he was not aware of being asked for consent, but he was just asked simply to sign the consent without being explained in detail about the study. So this is one useful tool which we can use to routinely check for any expressions of concern for any of the articles that we are planning to critically appraise. So, but just because there is a comment on Papier about any one article, it does not amount to misconduct because it is an anonymous tool and anyone can put up comments about any study under question, and they need not necessarily disclose what is their level of expertise in that. So we should also go into detail about the comment and verify ourselves whether the comment is legitimate or not. So are there other studies by the research team that highlights concerns? This again, we tried to enter in the research retraction database. When we entered the last author, who was Edward J. Mills, we came across that there was an expression of concern for one another study that he had done, which was about studying the adalimumab versus infliximab for the treatment of moderate to severe ulcerative colitis. And when we went into details of about why exactly there was an expression of concern, the expression of concern was because in their study they had used a different formulation of VSL3 and they had shown some benefit of VSL3 in IBD, ulcerative colitis. But subsequently, after 2016, the company that manufactured VSL3 had changed the initial formulation per se. So the study's findings was not directly applicable to the current version of VSL3. And after a court ruling, the study was asked to put up an expression of concern. And it is not a problem with the author per se directly. The second domain involves inspecting the study for conduct, governance, and transparency. And the first question is, are there concerns related to the ethical approval of the study? And with regards to ethical approval, the study's authors are supposed to tell when exactly the ethical approval is obtained and from which board was the ethical approval obtained from. In our study, the study authors have reported that they have got ethical approval from the local ethics board in Brazil and from the Hamilton Integrated Research Ethics Board in Canada as well, and they have given the approval number as well. But because they have not clearly told about when exactly they had received the approval, here again we have given an unclear risk for concerns regarding ethical approval. And if possible, the person who is analyzing the study is supposed to find out whether the panel or board granting approval exists and whether it has the authority to grant ethical approvals as well. And if any of these components are not available, we are supposed to give an unclear risk for concerns. And the second and third question under the second domain involves assessment of the trial registration with regards to timing and its inconsistencies. The second question is, are there concerns related to the timing or absence of study registration? And here we notice that the study authors have reported that they began enrolling participants into the metformin arm from January 15 and 2021. But whereas when we tried to enter the CTRA website and analyze the plan of the study, we noticed that the first version of the study protocol was submitted as late as 26th of January 2021, which is after the participant was recruited in the study. So, and again, with regard...
Yeah.
Clinical trials strategy, yes. And the third question was there any important inconsistencies between the publication and the registration documents? there were about 8 different versions published in the registry, and there were 8 different changes made across the arm. And metformin was there in the first and second version, and from the third version of the registry, we noticed that metformin was removed. And it appears that the study has been registered after commencement of the participant recruitment. Because it's a platform trial, it is acceptable for them to be changing the intervention arm and the control arm. So this per se does not raise concerns. But because the study was registered after the first participants was recruited in the trial, we have again given serious concerns for this domain as well. So here is the official changes that they have done in the platform trial. The latest version, the interventions involve checking the role of fluoxamine, fluoxetine, and a supplement called as spirulina, and there is no metformin per se in the current version of that trial registration. And the fourth question is the recruitment of participants implausible? Here again, we are looking at the consort diagram of the study. In this study, there were about 3,159 participants screened for eligibility, and after applying the eligibility criteria, 1,522 participants were deemed to be eligible, and of which 215 of them were allocated to the metformin arm and 203 of them were allocated to the placebo arm. Because this was a platform trial, there was several other ongoing arms, and about 1,104 participants were allocated to other arms in the trial. And subsequently, they had done both an intention to treat analysis as well as a modified intention to treat analysis and a per protocol analysis as well. So here we are given no concerns because it appears plausible to have these many participants considering that the study was done in the peak of the pandemic, and there were about 10 different sites which were utilized for recruitment of participants in the study. And they have also clearly given a consort diagram, and the flow of participants has been detailedly described. And the fifth question involves whether there's a possibility of conducting the study with the reported methods and resources. Here again, we have given no concerns. This is the protocol of the study that they had done. A participant who's enrolled in the study would have developed symptoms or signs of COVID-19. They were screened up to 7 days of onset of symptoms, and they were randomized either to the metformin arm or the placebo arm. The day of randomization was considered as day 0. And subsequently, the participants were followed up to 60 days, whereas the primary outcome was assessed at day 28. In between, they had planned for follow-up regularly at day 3, day 7, day 10, and day 14. And because the COVID-19 virus was highly transmissible, most of the follow-up was over through telephonic follow-up or through WhatsApp that they had planned for a follow-up. The in-person follow-up was only on day 14 after they were non-infectious for transmitting COVID-19. So for this, again, we are given no concerns because they've done the follow-up mostly via video teleconference or WhatsApp, and they have also utilized nurses and medical students for following up the patients. And funding and staffing was also described in detail, and it's considered to be plausible given the number of participants in the trial. The third domain involves inspecting the text and figures to check for plagiarism, tortured phrases, and for evidence of figure manipulation. For the first question involves concerns related to duplication or incompatible content. For this, again, we are given no concerns because one involves assessing the study for plagiarism and second involves assessing the study for tortured phrases. So what is tortured phrases? Tortured phrases are nothing but when we use AI softwares or softwares for paraphrasing to conceal plagiarism, the AI tool or the computer per se uses some unusual scientific phrases to change the word of the study, and this will be a marker for text manipulation. And there are many tools that are available online to detect these tortured phrases. So this metformin study published in Lancet, we had did a plagiarism check on our own using the Turnitin tool, and the plagiarism limit was within acceptable limits, and it was 15%. Initially, when we had run this tool, it had given about 80 to 90% because it had included the article per se in the plagiarism check. When we excluded the study per se, we found that the plagiarism was 15%. And this is one tool which we can use to identify any torture phrases, which is called as the problematic paper screener. And when we enter the DOI of the study per se, this computer-based tool per se can screen for torture phrases and give us a report for the same. So just one small exercise for those who are the audience here. Can you identify, these are excerpts taken from 3 different studies on COVID-19. Can you identify any tortured phrases that have been included in this study text per se? From the first, second, and third. And if you can find any, you can point it out. So like Felicia has pointed out, in the first study, we can see the paraphrasing tool has changed severe acute respiratory syndrome coronavirus into extreme intense respiratory syndrome, which is just the literal paraphrasing instead of scientific paraphrasing. In the second tool, again, can anyone point it out? Yes, again here for SARS, it has given a paraphrasing of incredible outrageous respiratory issue. And here again in the third study per se, instead of heart failure, the AI tool has given a tortured phrase of cardiovascular breakdown. Examples of tortured phrases. So, but in our study, we did not find any tortured phrases being used. The second question involves finding out if there is evidence of figure manipulation or duplication in the study. Here again, we have given no concerns. The study has given 3 figures per se, which showed the posterior probability of the event occurring in the metformin as compared to the placebo arm. And they have also given a graph showing the incidence of adverse effects, whether they were different between metformin and placebo. From the study's outcome, here the blue curve, the x-axis shows the event rate and y-axis shows the density. And the blue curve per se points to placebo and red curve per se points to metformin. Here they've used something called as the Bayesian statistics to show their outcomes. And the outcomes here is given in terms of probabilities as compared to the conventional statistical methods. We use Bayesian statistics if we are aware of some pre-test, before doing the trial, if we are aware of some pre-study probability of the role of metformin, we use something called as the Bayesian statistics. And the study's findings per se are applied to the pre-test probability, and it gives the Bayesian statistics will give a post-test probability of the outcome per se. And if the metformin was beneficial, what we would have observed is that the two curves being well separated apart, with the metformin curve being on the left side of the curve and placebo curve being on the far right. But here we could see that both of them are almost overlapping, showing that the difference was very minimal. And the curve on the right side shows the relative risk on the x-axis and the posterior density on the y-axis. And the blue, the part of the curve marked under blue shade shows the 95% confidence interval, and the extremes are marked in red here. So in the intention to treat analysis per se, the probability of superiority of metformin over placebo was about 28.4%. So again, the study per se has given the serious adverse events per se also, and there was no difference between the metformin arm and the placebo arm. There was no evidence of any distortion of the figures used in the study. And the fourth domain involves inspecting the results of the study under eligibility, allocation, baseline data, and statistical validity. And there are 11 checklists under the fourth domain. The first question is, are there any unexplained discrepancies between the reported data and the participant eligibility criteria? For this, again, we are given some concerns. The inclusion criteria mentioned that they would like to include participants over 18 years of age in the outpatient setting with mild acute COVID-19 recruited within 7 days of symptom onset, who are positive using a pan-bio rapid antigen tool for COVID-19. And they should have had at least one high-risk factor like diabetes, hypertension, obesity, asthma, or cancer. Or if they're over 50 years, they did not require any of the risk factors to be included in the study. So this is the list of all the inclusion criteria that was used in the study. And in the exclusion criteria, they had excluded participants who had had dyspnea due to other reasons apart from COVID-19, and those who had severe COVID-19 as defined by a respiratory rate of more than 28, saturation less than 90% or less than 93% on 10 liters of oxygen, PaO2 FiO2 by FiO2 ratio of less than 300. And if they had been on any of these following medications, which are all the other interventions in the platform trial, they were also excluded in the study. those with prior DKA and those with prior history of seizures and those with prior history of liver cirrhosis were also excluded from the study. And those with prior cardiac arrhythmias were also excluded because some of the trials in the intervention arm can cause prolongation of the QT interval. So this study evaluated the role of metformin, but here in the exclusion criteria, we did not find participants who have already been on metformin being excluded. So we are unsure whether at this point of time, those who were recruited in the placebo arm, what did the study authors do if they had already been on metformin for diabetes? So this part of it was not clarified in the study text or in the study images or in the supplementary material given along with the study. So hence we have given some concerns. So the baseline characters are also appearing plausible considering the inclusion and exclusion criteria provided. The typical person included in the study was a middle-aged female of mixed race with an median age of about 52. The most common risk factors being either obesity or hypertension per se with incidence of about 40%. There was some difference with regards to diabetes with 14.4% of the participants being a diabetic in the metformin arm and only 9% of the participants being diabetic in the placebo arm. Other parameters per se were almost equally distributed between both the arms. They have not given details as to what was the severity of COVID at the time of randomization in the baseline characteristics. So coming to the sample size also, the study authors had assumed an event rate of about 15%, and they had assumed that there would be about 37.5% relative risk reduction in the metformin arm as compared to the placebo arm. And they had used a power of 80% with a type 1 error of 0.05, and they had calculated a sample size of 681. And when we had calculated our own sample size, we had reached a sample size of about 535 in each arm, which was slightly lesser than what was reported in this study. The second question involves, is the allocation numbers implausible given the randomization method? The study authors here have used a stratified randomization wherein they have stratified the population into age less than 50 and age more than 50. And they have also stratified based on the site of trial where they were recruited. And the randomization was carried out in blocks of 8. So in blocks, it means that if there are 8 participants in the every 8 participants that are recruited in the study, 4 will be in the metformin arm and 4 will be in the placebo arm. But the difference between the metformin and placebo arm amounted to about 12, which would not be plausible if the study was not stratified and it was just based on the block randomization method. Because because stratification was followed in the study, it might have been plausible to have reached these numbers. But if these numbers were arrived directly just because the randomization was done in blocks of 8, these numbers would be implausible because if we have about 4 participants left over in the last allocation block of 8, the highest plausible difference between both the arms would be that only 4 would be higher in one arm as compared to the other arm. But here the difference was about 12, which is probably because they had used stratified randomization. Allocation was also concealed because here there was an unblinded pharmacist who gave treatment codes for each of the treatment packages. And whenever a participant was recruited, the clinicians contacted this unblinded pharmacist through WhatsApp to get that coded treatment package. The clinician was blinded in the study. And a randomization list was also kept confidential by the unblinded statistician to maintain randomization and allocation concealment. So this is the consort diagram of the study. Here we could see 215 participants were allocated to the metformin arm and 203 participants were allocated to the placebo arm. And is any baseline data implausible? Here again, we have given no concerns considering the baseline characters that we had seen previously in the study and applying all the inclusion and exclusion criteria to our study. We could not access any individual patient data or the data set of the study to assess for any other problems with regards to the baseline data. So this is from another study from JAMA, which I would like to point out. If at all the data set was available, how we can point out to any discrepancies in the data set. I would like to ask the audience here to see this data set and see if you could identify any discrepancy in the data set in the study. Just with regards to the name and the gender per se. Yeah, like Vineet has pointed out here, we can see in the data set, the 30th person in the study is Rebecca, and the gender is given as male. Likewise, similarly, here the fourth person is Jessica, and the gender is given as male. So these are all probably not authentic study participants per se. So if at all the study data set is available, we are supposed to go through the data set in detail to find out if there are any discrepancies like this. Yes. So Fenicia is asking just if we can go just by the name to justify the gender, and whether it is ideal for the study to report the study participant's name per se, because it will breach the confidentiality. Like that. So this is in the study, in the participant data, they have actually revealed the participants' names per se, which is, yes, which is not actually ideal, and it is a breach of the patient's confidentiality. And the fourth question involves assessing whether there are any discrepancies between the results reported in the text and the figures and tables. So here again, we have given yes under serious concerns to this question, because the primary outcome data was given differently in the table and the text per se. So in the intention to treat analysis, there were 34 participants who had the primary outcome. And in the placebo arm, there were 28 participants who had the primary outcome. And in the text, they had given the incidence of primary outcome to be 13%, whereas in the table, they had reported the primary outcome to be 15.8%. And again, in the placebo also, the text said the primary outcome was about 15.1% in the placebo group, whereas in the table that they had given, it was 13.8%. So this was contradictory to each other. So hence, we have given a serious concerns again here. This is probably because they consider the population at risk to be different when they did the calculation in the table as compared to the calculation in the text, though the number of events seem to be similar in the text and the table per se. And are the numbers to loss to follow-up implausible? Again, here we have given some concerns, because as per the consort diagram and in the uh, final analysis, they have said that uh, all participants in the metformin and the placebo arm had completed the study, and there was no loss to follow-up. And there was only concerns with regards to treatment adherence, wherein about 22% of the participants were not compliant to metformin, and 11.8% of the participants were not fully compliant to the placebo. So there is some doubts as to how they exactly all 400 participants followed up. They attended all the phone calls, gave details required for the study. All of them attended the in-person follow-up at day 14. That seems slightly implausible. The analysis population they included was: one was intention to treat, second was modified intention to treat, and third was a per protocol analysis. In the intention to treat analysis, all participants were randomized at the beginning to the metformin, and the placebo arm were analyzed in the same group per se till the end. And in the modified intention to treat, those who had received the study drug for at least 24 hours before reaching the primary event were analyzed as the denominator. And in the per protocol analysis, the denominator used was uh, at least 80% of adherence to the metformin or the placebo, which was 47 and 24 as per the consort diagram of the study. So here we could see the intention to treat analysis had a number of 215. The modified intention to treat had a number of 211, and the per protocol group had a number of 47 in the metformin group. And in the placebo group, the numbers were 203, 203, and 24 per se. So the sixth question involves us to find out whether there are unexplained inconsistencies in the number of participants. We saw in the sample size calculation that they had planned to recruit about 681 participants in each arm, which amounts to about 1,362 in total. But the final sample size that they had achieved was only 418. But despite this, we have given no concerns, because in the study protocol per se, they have said that they will be stopping the study for futility if they found out that the probability of superiority was less than 40% for intention to treat analysis when they did the second interim analysis. So because their posterior probability was about only 28%, they have decided to stop the ongoing recruitment, which did not give us any sense of concern. And is any outcome data or treatment effects implausible? Here again, we are given no concerns because they had expected a controlled event rate of the primary outcome to be about 15%. And overall also, they have almost achieved about 14 to 15% per se in the intention to treat analysis that they had done. And they did not find any difference as compared to in the metformin arm as compared to the placebo arm. And the relative risk was 1.14 with the Bayesian confidence interval crossing 1, meaning that the difference was not significant. And this was a subgroup analysis that they had done, where they had stratified participants by age, gender, BMI, based on whether they had diabetes, pre-existing lung disease, and from the time of onset of symptoms, and by smoking status. And in all of these subgroups, they did not find any statistically significant difference in the metformin arm as compared to the placebo arm. And are the means and variances of the integer data impossible? Here again, we have given no concerns. In the baseline data, the only place where median and interquartile range was given was only with regards to age, and whereas the other parameters were mostly categorical variables. And this also seemed to be plausible, and hence we have given no concerns. So if at all we are appraising some other study which has means and standard deviations reported, these are some tools that we can use to find out whether the statistically given values are plausible or not. One involves the GRIM tool and second is the GRIMMER tool. And I have given the links for the same to access the same to check for whether the plausibility of means and variances are possible or not. And other errors in the statistical results. For this domain of 4.9, I've given serious concerns because there were some errors that we could point out in the per protocol analysis per se. If you could recollect in the consort diagram per se, we saw that in the per protocol analysis, the total number of participants included were 47 in the metformin arm and 24 in the placebo arm. But the image per se did not correlate with the table that they had provided. Here we could see the number at risk was 168 and 179, which was different from the number at risk which was provided in the consort diagram of the study. So this per protocol analysis was not considered to be appropriate. And with regards to other primary outcomes and other in the intention to treat analysis and the modified intention to treat analysis, the relative risk given for the primary outcome, which was subsequent hospitalization or retention in the emergency setting for more than 6 hours, the relative risk was 1.14 with a confidence interval of 0.73 to 1.81. When we entered this data in using the Pedro tool, which assesses whether the statistically given confidence interval was correct or not, and we entered the same event rate, and we found out that the relative risk was also similar with 1.14, and the Bayesian confidence interval given was also similar to what was reported in the study. And we also tried applying the Pedro tool to the incidence of adverse events. And when we entered the event rates of adverse events in the metformin and the placebo group, we found out that the relative risk that was calculated was also similar, with the confidence interval that was reported also similar to what was reported in the study. And the 10th question involves finding out whether there are any other contraindications that are implied by the data. Here again, we are given some concerns because in one subgroup analysis that they had done, the odds ratio of the primary outcome for those with diabetes mellitus was given as 0.95 with a confidence interval of 0.51 to 1.78, which meant that it was not significant. But in the study text per se, the authors had concluded saying that for patients with diabetes, the odds of primary outcome was less with the 0.95 favoring metformin, which we found was not correct. And is there any inconsistencies across multiple publications describing the study? For this domain per se, we are supposed to go through the trial protocol, and if there are any pre-conference abstracts which have been published in other conferences per se, we'll have to look up those results and see whether the final published results are correlating with whatever was published in the conference or the pre-conference abstract presentation. And they should all be correlating and should be providing similar values. So here we could not find out any conference abstracts or anything per se, but we found out the trial protocol being published, and the study protocol per se was largely consistent across the sample size reported, the interventions, the primary outcome definition, the eligibility criteria that was given, and the follow-up duration that was reported. So hence we have given no concerns per se. So summarizing all our evidence, for domain 1, we have given serious concerns because our article was retracted, and before retraction, there was an expression of concern that was given. And for the domain of conduct and governance, there are some concerns with regards to ethical approval where they are not given the dates per se of the things being done, and hence we have given serious concerns. The text and figures per se, we did not find any plagiarism or any torture phrases, for which we had given no concerns to the overall domain. And for results in the study, we noticed that the per protocol analysis was, the numbers were different in the text and the consort diagram per se. And this was the main reason why we had given serious concerns. Hence, overall, for concluding this inspect SR checklist, overall, I'd like to give a serious concerns for the trial per se. And this is one another upcoming tool called as the Inspect AI, which is not currently available yet. But once available, this will be an AI-based tool, which will be which we can use per se to assess the trustworthiness of the study using this AI-based algorithm, wherein we can just upload the PDF or the link to the study per se, and the AI artificial intelligence per se will do the trustworthiness check. And based on this, our critical appraisal of trustworthiness, should we include this together trial in our planned systematic review on metformin and COVID-19? Because there were serious concerns in 3 out of the 4 domains, I would not like to include this trial in my systematic review on metformin and COVID-19. I'd like to thank Dr. Tambu sir and Dr. Vignesh sir for helping me with my presentation.